I hear the world, a distant memory, the sound of silence surrounding me like a symphony without a score, a perfect storm without a shore. I wanna hear your voice calling out my name, a life-changing noise. I'll never be the same. Let's hear the world like you never did before. Hear the world, let's open up that door. Hear the world, it's time to lend a helping hand. We hear the world, I hear the world loud and clear. I feel this music instead of tears. I hear the world, no ifs and whys, the chant of birds up in the sky. And I hear your voice calling out my name. Now I'm like you and you're like me, we're all the same. Let's hear the world like we never did before. Hear the world, let's open up that door. Hear the world, it's time to lend a helping hand. Everyone sing out across the land. Raise your voice for those who can't be heard. Speak out loud, put out the words. Hear the music, hear the word. 'Cause love is all we need. Let's hear the world. Hear the world. Let's hear the world. It's time to lend a helping hand. Everyone sing out across the land. We hear.
Hi, good evening, everyone. Welcome to the fourth FB Sound Life Facebook Live. Today, we are going to share about second chance to hear again, and we are honored to invite this time Prof. Gorbisi, which is a senior ENT surgeon from UKM. She is also the head of CI cochlear implant program, who have performed nearly 300 surgeries to join us tonight. Good evening, Prof.
Hello, good evening.
Hi, good evening.
Everyone.
Good evening, everyone. So I would like to know, currently we have some audience here. So do you mind to share with us, say hello, and then tell us where are you coming from? Hi, Jeff. Hi, Sharon. Good evening. So, Prof, today we are interested to know that because UKM has been starting this CI program since 1995. So when I see CI, it stands for cochlear implants, just in case some of the audience over here are unsure. So UKM is also started this program since 1995, and it's the first program in Asian country. And currently, you are also the head of CI for UKM. So would you like to share with our audience how soon we can diagnose the hearing loss?
Okay, I think nowadays we can do everything fast, right? So actually, to make the diagnosis of hearing loss, it can be done very soon after birth, and this is possible because of the Universal Newborn Hearing Screening Program. Some may heard about it, some may not, because not all the hospital will have this program. I think in Malaysia, our hospital is one of the pioneer in conducting or started this program, Universal Newborn Hearing Support Program, because we do not want just to screen babies who have high risk. High risk means they are born premature, or they have other syndromes. But this is the child who are born looks normal, but we want to screen them. So in different hospital, they have their own protocols. It can be done like one stage or two stage screening, but one of it that we can share here is the one from MOH, Ministry of Health. They do have this screening protocol. In our hospital also we do two stage. Two stage means before the babies are discharged home with the mom, there is a screening done, and if it's passed, they will be discharged with advice. But if it's refer or fail, they call it either refer or fail, then they will be given appointment to come back to the clinic, because we need to screen them by the one month and to diagnose them by 3 months. So it means that after the second screening, depends on the result, pass or fail again. If it is fail or refer, then we need to do the diagnostic. And as we say that by 3 months, must diagnosed, by 6 months, 3 to 6 months, we should start with some form of intervention program. This is important because almost like 1 to 3 in 1,000 of babies are born with hearing loss. So we talk about screening either using OE or AAPR. So this is where audiologists will do their job, or this is their responsibility. So Alia, do you want to share with the audience what is this OE?
Yes, sure. So for the OAE, this is actually one of the video that I can show with all of you for the OAE. So as you can see, as long as the baby is actually quietly sleeping, then we can just insert the probe inside their ear, and the test will be finished within like 20 seconds like that. So the OAE test is mainly to test the baby cochlea, whether the outer hair cell function is normal or not. So if let's say the OAE, the outer hair cell is actually function well, then we will get the result. There is some response, there's some emission from the ear. So as you can see from the side picture of this, which is this one, inside the probe, actually we have a microphone. We also have the probe. We have the microphone and we have the speaker. So the speaker is the one that produces the sound to the baby's ear. So if the baby's ears inside is actually having this cochlea, and inside this cochlea is actually having the outer hair cell. If the outer hair cell is normal, then the probe is able to pick up some emission. So that is where we will get the baby's hearing, whether it's normal or not. However, the OE result, when we get the normal result pass, it also means that the child has hearing better than 30 dB. 30 dB, our normal threshold is 20 dB. So if better than 30 meaning to say those are having very mild hearing loss, we will tend to miss out as well. And also this test is only tested at a higher pitch, which is the normally 2000 Hertz to 5000 Hertz. So for those who are actually having some low or mid frequency loss, then the OAE test may actually give a false result as well. So another test, like just now Prof, you mentioned, after we do the two-stage screening, if let's say still got the referred result, then we have to do the diagnostic test by 3 months time. So normally this diagnostic test is for baby. It's called auditory brainstem response. And what we will do is we will put some electrode around the head, and then we will put the insert earphone and give them the sound as well. So when the baby hear the sound, the brain wave will be actually recorded and then being amplified. So over here is some of the sample result that I have. If let's say the child is able to hear very well, then we will test from loud sound 70 dB down to 20 dB, and we will get the response there. As you can see, the waveform can show very nicely, and then we will get the wave 5. But if let's say the baby is having some hearing problem, like for example, this red color, it only can show the wave 5, very clear wave is at 70 dB. So we will diagnose this child is having severe hearing loss, at least have high fluency. So that is how we tested the hearing.
Okay. I think just now before we started the live, uh, I heard some music that you play that stimulate hearing loss. Do you want to play back again and explain a little bit more about that?
Yeah, sure. So actually, over here I have some music, which is about sorry, um, all right. I'll share some screen. So this one is a music for a normal hearing. As you can see, if let's say we have normal hearing, we can hear it very well, the music.
The sound of silence surrounding me like a symphony.
So this is a sample of people here when they have mild hearing problem.
Without a shore.
And this is when they are having this moderate hearing loss. As you can see, the sound is very different.
We hear the world.
Yeah, if normal, we hear very clear.
Let's open up that door.
This is when the child is having, or anyone is having this severe hearing loss. So generally, they will miss out the conversation, but the music is like hearing much lesser.
Everyone sing out across the land. We hear the world.
So another one is actually profound hearing problem. So technically, profound people is normally, if let's say without intervention, they will become deaf and mute as well, which is not able to hear. So this is a very short illustration about the music. Okay. So we have, when we diagnose the hearing loss, we actually diagnose it according to the levels. Like for example, degree for hearing loss, just now I already demonstrate some of the hearing loss degree, like mild, moderate, severe, and profound. Yeah, this is how we do it. So Prof, actually there is something that I want to ask you. Like for example, can you explain a little bit why it's so important to understand, to address this hearing loss in children?
Okay, I think hearing loss is something that you can't see, because when we say disabled, physically disabled, it is some disability that you can see, anyone can see. But hearing loss is a silent disability. Nobody will know that by looking at you, you have hearing loss. So the disability that actually can be cured by using any some form of hearing device. So if you look at this girl, she was wearing the taekwondo costume there. She can play taekwondo, and the other boy, young man, he's handsome and he attended some kind of ceremony. But he actually has hearing loss. So I want to share my thoughts about what are the ways. And there are some ways where hearing loss has caused an impact to those, especially children. We're talking about especially in children. So what are the ways? One important thing is when there is no hearing, there is no speech and language. It means there's no communication skills. So when there is delay in this development of the communication skills, where there is no receptive and expressive speech and language, they will have learning problems. So when they have learning issues, these deficits will result in either reduced or poor academic achievement. This also will directly affect these social problems. They start to isolate themselves. And then it also will affect the choices of vocational. So I would like to share with you one of the articles were published in 2018. This is our experience where we look at the cohort of our pediatric cochlear implantees. How or what is the outcome for this? So this is a busy slide, but I just want to say that this slide is showing the patients that we studied at that time. Majority of them, almost 80%, are due to congenital hearing loss. That also have 5% of disability, other disability, and the scans have 15% mild to severe form of abnormality. So what did we study? What are the objectives? There are two main objectives that we look at. One main objective is to look at the mode of communications. Mode of communication means we want to see whether they can speak. That means they're using oral language. So that cohort from the patients implanted in 1997 until 2012. That cohort of populations, the implanted patients, 60% were able to use oral. But there are another 40% mixture of either using sign language, full speech, or total communication. Another main objective from this study is to look at the education system. So I think we know that if you can't speak, you don't have communication skills, you can't go to school. Yes, you can, but what about the type of school that you can go? So that was reflected almost directly. You can see here there's 58% were able to enter mainstream school, and there was a quarter of them at the time had to attend or be enrolled in the special school. But this is the study that we have, and we look at what makes a difference. Okay, so when we look into the mean age of implantations of these two group of patients, the first group of patients are those with oral communication. When they are able to use oral, the mean age of implantations were at the 3 years 2 months, 38 months. But another mode of communications group, they were implanted with the mean age of 44 months. That was only 3 years 8 months, not even touching 4 years old. And it reflected again in the school placement, whether they are mainstream or not. So they are almost the same mean age group because they are the same group of patients. Okay, then we look into a little bit more detail about the age of implantation when we look at the other factors, but we found that the age of implantations is crucial and important, causing this or resulted in this outcome. So when we look at the age of implantations, we analyzed the age of implantations. We found that when there was a delay in the age of implantations, we will have the odd ratios of not able to use oral language with the percentage. I think there's a graph after this. Alia, you can show. Okay, that's what we say at the lower of 2.6%. And again, what about school placement? What is the odds? You look at the next slide. It's showing you that the age of implantations, that any 1 month delay will also causing the delay in the entering mainstream school, because there is a risk of 3.3% of not able to enter mainstream school. So I think that is what we found.
I see. Prof, meaning to say that if let's say the child has been diagnosed with hearing loss, and if they don't receive any intervention, it's going to affect them whether they can develop the speech and then to also able to enter the mainstream school or not. So I have a question here. Actually, what happened to the baby's brain when they are having hearing loss, and sometimes parents is overlooked and the child didn't undergo any newborn hearing screening that we have mentioned earlier. So what happened to their brain?
We have ear, but hearing process, we must remember that we must have the impulse of the hearing reach the brain, because ear is actually the doorway to the brain. When there is no hearing, that means when there is hearing loss, what happened was the area of the auditory pathway is blocked. So there won't be any speech and language development because there is no connection from this auditory cortex and the speech and language cortex. Scientifically has proven that baby actually can hear when they were in the mother's womb. No, as early as 24 weeks, they already started to, so from 16 weeks, actually they can detect sound. And when the baby was almost 6 months old, they can actually respond and localize the sound. That's why if you remember, some mother may want to put like the music on the baby's womb,
Yeah,
and
yeah, yeah.
listen to some nice music because the baby can hear. So if they can't hear, the effect was what I mentioned earlier. It will affect the speech and language, the communication, the schooling, the future, causing the social isolation and increase the poverty. So it is crucial to intervene earlier because our brain development is important in the first 3 years of life. So that's what I like to say. It is a golden age. And that's where I like to use my ambulance to say it's important. The neurodevelopment emergency is to understand how urgent we must diagnose, we must intervene because the brain, speech and language area, auditory cortex will not develop well if not intervene early.
It's true, it's true. So over here, I also recall that there is one patient of me. When I first seen her, is already 11 months and have been diagnosed with this moderate hearing loss. Then after that, the parents bought the hearing aid for the child. But because the child was taken care by a caregiver, and the caregiver need to take care of the sister as well. So sometimes she just forgot to put on the hearing aid. So at the end, when the child come back to me now, is the age of 3, the speech is only still a single word. So we can say that if let's say the child is without any intervention, definitely it will affect their speech development, and the following problem will be also follow up as well. So that is quite sad to see that. Yeah. So, Prof, over here, I would just like to introduce to the audience that some of the steps that audiologists will do for the intervention. If let's say we already have this, then we have to identify, and then we also have to do some intervention to address the hearing loss.
Yeah, I think that's
Okay.
where after they were diagnosed, and we also would like the audiologists to come in and help in the management, because there are many
Yeah.
types of device where the audiologists are the experts. So I think this is the time where you can share with us.
Okay, sure. So I would, because many of you may not be very familiar with some hearing aids. So over here, I just give an overview. So nowadays, hearing aid have many styles. As you can see from the picture, there is something very small. Like we have this custom made IIC invisible in the ear. When you put it on, you can't see it well. Or we also have something called the RIC receiver in the canal. So even though you put it, because the hearing aid is so small, people can't see. Or not only that, some of the latest hearing aids also comes with rechargeable function, whereby no need to change those like tiny battery anymore. Last time, every 7 days have to change, but now one charge can last more than 15 hours a day. So not only that, the latest hearing aids also comes with Bluetooth function, where the user can pair the hearing aids with their phone or with their PC, and then when they do this like Zoom call or even the normal calling, they can actually use the hearing aids to answer the call and then directly communicate to the other party. So then we also have these hearing aids nowadays come with some apps Like this is a sample of remote control app from Auticon. So the benefit of using this app is they can control their program according to the situation, the volume, and so on and so forth. And not nowadays, because of COVID happened, right? So I can see a lot of manufacturers also come out this function, which is called teleaudiologist, the remote tuning. So what happens is that if the user is using the hearing aid and stay at home, and we are in our office and they just feel like not convenient to come to our office, they can actually use the app, log in, and then dial us. And then from there, we audiologists at our premise can actually do the tuning for them. So this is some of the latest technology of the latest features of the hearing aid technology. And then, however, for children, we normally we fit them with the BTE type, which is behind the ear, and with this ear mold as well. So why we have to fit these hearing aids? Because baby ears keep on growing. So I understand some of the parents sometimes they come to us and say, "Oh, Miss Ching, I want to fit those are very tiny one," but it's actually not very suitable until the baby grow up to maybe age 15, 16, then it's okay to change to the other style. So not only the hearing aid fitting, but we audiologists will also do some of the things like audiological follow-up. So for children, because we wanted to monitor whether the parents put on the hearing aids for the children. So nowadays with the hearing aids, we do have a features called data logging where we can track the children usage. So we will ask them to come back every 3 months, and then we will check the usage. And then from there, we will also perform some of the audiological follow-up for hearing aid, like for example, rear aid measurement, the aided testing, and then the questionnaire to understand the children performance after using the hearing aids, whether is it okay. And once everything is like stabilized, we will also refer to speech for the speech therapy. So this is basically how Sound Life manage children cases. So Prof, I do encounter some of the young children who is like already developed speech, but they are still very dependent on lip reading. And sometimes they still struggle to hear. Will cochlear implant actually a better choice for them? Maybe you can explain a little bit about CI to our audience.
Okay, cochlear implant is an option for severe to profound sensory neural hearing loss. And criteria is usually bilateral severe to profound hearing loss, either prelingual or postlingual. Means either they are born with hearing loss or later on they develop progressive hearing loss, or even those who had infection or something that caused acquired hearing loss. But to do a cochlear implant, it doesn't mean that you come today and tomorrow we do the cochlear implant for you. It's not just only to do the surgery. There is a team that managing the patients, because there is candidacy selections. We have audiologists in the team. We have the speech and language therapists in the team. We have the medical professionals, either pediatricians. If they are children, we usually have this subspecialized in the child developmental pediatricians. We do radiological examinations, and we also sometimes need psychologists or occupational therapists or physiotherapists to come and assist us in the assessment, because we need to assess them, and then only we can decide whether this is a good candidate for cochlear implantations. So one of the things that we and the ENT and medical will do is the imaging. We need to do a radiological examinations, because like CT scan is something important, as it is looking at the bony structures. When we say bony structures, means we want to see the cochlea, and the normal cochlea is 2.5 tons. But there are students who are born with 1.5 tons or less than that. We have this cochlear abnormally, or the temporal bone structures is abnormal for surgery. So it is important to look at and study the CT scan. We also need MRI. MRI is to look at the inner ear structures, mainly the nerve, the 8 nerve, the hearing nerve, and also the brain. In our protocol, we started to look at to include the brain in the MRI protocol, because we found out there are children have some abnormal global delay as well as learning problems, they do have some abnormality. For example, this scans, this MRI is showing there's a cyst in the temporal lobe area because this child has a typical CNV pictures or features, which was only diagnosed on the MRI because there was no screening done for CNV before. So this is where the MRI and CT scans are very helpful. In addition to what I have mentioned, the hearing assessment, because if hearing aids has some limit. If it's already reached the limitations and optimally fitted, uh, these are the group of patients should go for cochlear implantations. Of course, cochlear implantations will be done under general anesthesia, and this is done by the ENT doctors who are specialized in ear surgery and trained in cochlear implant surgery. The pictures, one of the picture is showing the skin incision is only about maybe 2 to 3 centimeter, about an average of that, behind the ear or the site of the implantations. And we place the implant, which has the electrodes that will be inserted into the inner ear or the cochlea by doing mastoidectomy.
Interesting. So, doctor, I don't. Some parents will ask me these questions, even though I know it's not realistic, but they will ask something like, after the surgery, can they hear the next day? So, how would you answer that?
I think this is what the parents always anxious and ask about, So I would tell them, well, cochlear implant surgery is not a magic where today you do surgery, tomorrow you can hear, tomorrow you can talk. So I told them that this is a process. There is a process. The admissions and the cochlear implant surgery is only about a maximum of usually I'm talking about average case is 4 days, 3 nights in the hospitals. And most of the time after second day, the 1 day surgery, it's the second day, first day, second day, they can go home. And you can see this is post-op day 2. The parents are so happy taking selfie because the child is also smiling. So it's actually pain. The pain is minimal, and the girl happy off the bandage. The second day can go home. So this is usual way of post-op care where they only admitted for a few days, they can go home. But then again, when can they hear? You must remember cochlear implantation has the 2 components. One is the one that I implant to inside the mastoid and the inner ear. Another component is something outside that is called externally is a sound processor. So you need this processor to be on attached to the electrode to the magnet of the implant receiver, and the impulse only can be sent to the electrodes. But don't forget, this is electrical things. This is not like hearing aids where they just amplify the sound. So it means there is a switch on date. Switch on means put the things on. And this is done about 2 to 3 weeks after the surgery. When the wound has healed, there is no issues. 2 to 3 weeks is the time where we can put on the sound processor, and we call it as a switch on day, where the child is here for the first time. But subsequently, there is a need of mapping because the electrodes inside there need the audiologist to check and to put this what we call as to set the hearing level, the sound not too loud and also not too soft, so that the child can hear.
Yeah, I still remember last year I went to UCAM to attend this cochlear implant the talk which is organized by Cochlear. So now we are proud to say that Sound Life will be actually waiting for our very first patients who maybe can do CI. Then we will also refer to UKM, and then from there I hope to also improve my clinical experience about this mapping and switch on as well. So next, doctor, other than these 2, right, what happened to the kids after the switch on? So what are the other things that we need to do?
Yeah. So as you can see here is the rehabilitation. I mentioned in earlier on, the selection criteria assessment include assessment by speech. So
Mm.
speech language pathologists or ABT, auditory verbal therapists, they are the experts. They teach the child to hear and to speak. But this is not something that can happen within a day or two. We teach the
Mm.
child, but we also teach the parent. So the speech therapist is usually guiding the parents on how to communicate, how to train the child who has cochlear implant to hear and to speak. Because we need to listen to detect the sounds. Then we have to think about what is that. So our brain needs to analyze what are all these sounds all about. So that's why we say it's important to intervene early. If you have never heard a sound, you can hear but you don't understand. So
Mm.
hearing and listening are two different things. You can hear me, okay? For example, like we go overseas, we go to somewhere where they don't use English, they use their
Mm.
own language. We have normal hearing, we can hear, but we don't understand. Our brain has never learned that particular language before. So that's why the
Yes.
brain development, the speech language stimulations are something that need to start very early. I think for us, at my age, maybe ask me to learn some other language, I think it's difficult. Even though I can hear, but I cannot understand.
Yeah. Not only your age, doctor, now if you ask me to learn a new foreign language like Japanese, Korean, I would say that it will be struggle for me as well. So, Prof, other than that, what other than the rehab, right? Normally, just now you mentioned, we not only train the child, but we are training the parents as well.
Mm.
So, and there is one goal that I'm sure that we hope that the child can actually catch back the speech that they have, the speech development that they have been missing. But generally, how soon is a child able to speak after the CI generally?
We are talking about average lah, yeah. Average
Mm.
is about 6 months to have some words. That is earliest. There are
Mm.
some patients who drag to 9 months, but we are
Mm.
expecting something at 6 months of age. So that's why the need of this therapy intensive. We say intensive. Intensive
Mm.
means you're not coming only to speech therapy once a week, but the whole day, the time that you spend with your child is the time where you try to do the kind of therapy because they need input. The brain will
Mm.
need input. They never heard that sound. They're not going to say that words, isn't it? So how
Mm.
soon they can say? We are talking about average of 6 months, but something that we need to train. That is all about brain plasticity. Our
Mm.
brain to need to be they need to they need all these connections, and I mentioned the critical periods already. In the brain there are synapses. If you, for example, you have a child, somebody come and you will say, oh, this is Kong Kong, for example. It
Mm.
You never say this, the picture of the, I mean the Kong Kong is there, the baby will never know that is somebody called here Kong Kong. And if we
Mm.
say Kong Kong, if there's no one in front of the baby, how does he know that Kong Kong means this person or somebody? So this is where
Mm.
environment is also important. When we say environment means if you see the next slide, we talk about the 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 brain is born with certain numbers of brain cells, and how the experience and the environment will make the child to remember as well. The storage of this understanding the speech and develop the language. Something that in I can just use as example.
Mm.
Durian. We Asian love durian. Not
Mm.
everyone, but majority. Because we have tried before and we love it. But if you have a baby of 1 year old or 2 years old, you put in front of the baby or the child durian. If they never know that is durian is sharp, they actually touch the durian, right? So
Mm.
environment, experience is important. If they touch is sharp, it's causing pain. They will like, they see the durian, they won't touch anymore.
Yeah.
So you
Learn
need,
by experience.
yeah, so they need to have memory, and to
Mm.
hear, to speak properly, you must be able to hear properly. And it
Mm.
must be able to hear with the good hearing level.
So I also remember that for audio for listening process, we do say that we have this detection phase. After you detect, you must be able to discriminate, which is you differentiate two different sound or two different words. Then after that, you are going to become able to identification stage, which is memory the sound, and then the last one is actually comprehension to understand. So like what Prof you mentioned is like how usually for a word lah. In general, the baby need to listen how many times then only they can pick up and speak up the words. Do
So
you have
many.
ideas?
This is, I think if you there is some research they do research on how, but I can't remember exactly. But it's not something like 10, 20, or hundreds. It's
Mm,
times. Talking about thousand.
mm,
Listening properly, then only they can hear and speak properly. So I think these are
yes.
most important part that we must understand when we are looking into pre-legal child who are born with hearing loss.
Mm, okay. Prof, I also have this line. Just now you say it's an emergency.
Yep.
So this one actually show that the different development for the baby always happen on the first year, right?
Yes.
First year, like the hearing first will start first, then the speech, and then after that, the higher cognitive function will happen later on. Mm.
So if you can see the graph, actually there's something negative, right?
Mm.
Because baby, the fetal started to detect sound even before they are born.
Mm.
That's why the graph you can see there's a negative part. Before they are born, they are
Oh,
really able to hear. The
I
first
see.
first 2 3 years is the most important stage, the optimal stage. That's why I like to use my ambulance. I would say that when you have ambulance, not only those who have heart attack or acute appendicitis need to be treated early. Of course, those need to be treated accordingly. But I just
Mhm.
want to highlight that when you have a child born with hearing loss, please remember it is also important. It is also
Mm.
urgent. They need the hearing test early. They need to be diagnosed early. They need hearing intervention early. If not, they will die of something else. Is the future education? They are unable to enter mainstream school. They are unable to achieve what they can achieve as a normal hearing kid.
Yeah, right. If let's say they have any disability, not only happen to hearing, but if let's say for vision, also we need to address it. So, of course, since UKM already run this CI program for 25 years, can you just share some of the success story of the cochlear implantist?
Okay, we have many. We have so
Mm,
many, but I can share a few of them who are still keeping in touch with us very well. One of
mhm,
the girl in whom we implanted even in early 2005. Okay, in
mm,
early 2005, she was only 11 months old. Miss Endong, she was implanted early because she was diagnosed early through the newborn hearing screening at 2 days old. So there is a diagnostic test, and the parents understand. They went through all the assessment and managed to do the cochlear implant even in the year of 2005. And
mm.
with the you can see she was wearing the uniform with the like a prefect. She is.
Yeah.
She was the head prefect in the primary school, and she received a lot of certification because she's one of the best student in her class. She got her UPSR result, excellent result. She can play piano. She enjoy music. She enjoys swimming. So this is one of the girl that she's already 17 years old now, but this is what she is. She's looks like she's better than those with a normal hearing child.
I
So
see.
yeah,
Wow,
there
that
is
is
another
very
child.
impressive. So
Yep.
I can say that because the child is having this CI early, surgery done early, and then she have a very good near to normal hearing. That is why after that the hearing problem is no longer affect her development, her
Yeah.
pursue in piano, in other things as well,
I
and
must I
now she
must
can.
honor that her mother, her parents are
Mm,
very good in doing the therapy. They are like
mm,
at home to do all this therapy. She learned. The parents and especially the mom actually
mm,
look to the program for speech and language, and she learned. So because she knows that that intensive part can only be done a lot more at home by the parents.
Yeah, I do met with her parents once, and then I met with Mr. Raymond, right?
Yeah.
Raymond. So then he shared a lot of story to me as well, and then I also bought the book from him. So they are very good because they understand that during that time there is many parents who are lost. So that's why they use their own experience to write the book, and then to encourage other parents. So I also like their books as well. So Prof, what are the other story case that you can share with us other than Andong?
Yes. So there's another child, as you can see. He was implanted at the age of 2 years old when the program was our program started in 1995. In
Second, the third year.
yeah, in 1997 we implanted a few children. So he is
Mm.
one of them. Lepeng, he knows that we will use his picture. He's given his consent. He had syndrome. He had a syndrome, but this syndrome, we must understand, not all the syndromes cannot do cochlear implant. This
Mm.
assessment, this should be assessed because, like this child, even though he has Waardenburg syndrome, but his cognitive function is not affected. He had implantation early. Again, the parents are superb at that time. 1997, do a lot of intensive therapy, and he was able to have verbal language, oral language, entered mainstream school, and obviously you can see one of the university. He was in Hong Kong, one of the university, and at the end, he graduated from University of New York. He had a degree. This
Wow.
happened before MCO. No, he managed to attend his convocations. That was like few months before MCO. So that's where that picture was taken when he was in New York with his parents and his dean. So to see this is what they can achieve. There are many.
Wow.
There are so many.
Mm. So, Prof, how young can a child do the surgery? Because I do have parents sometimes will ask me, "Oh my God, they are so sad." Of course, they already passed through the emotional struggle, like already accept that their child is having hearing loss. Then they will ask me, "But my baby's so young, I don't want them to go for surgery so fast. Can they go later?" So how should I actually answer that questions?
I think, of course, this need to be answered by the surgeon. The surgeons
Mm-hmm.
who do the surgery is the only one who should be able to explain the risk, risk of surgery, and the anesthetist is going to discuss about the anesthesia part. But we
Mm-hmm.
must remember that nowadays we have subspecialty. We have pediatric anesthetists as well to deal
Mm-hmm.
with these complex cases. So FDA approved cochlear implantations for children's 12 months old. Sorry, but that was many years ago when they approved
Mm,
12 months old. Nowadays, they have already reduced the age to certain implant where they can be implanted at the age of 6 to 12 months old. So it means
mm,
that it can be implanted even before 12 months old because the baby should start babbling a few months
mhm,
old, and they start to have their first words
mm,
range from 9 months to 1 year. They should have.
mm,
So why can't we implant them early if we can diagnose them early?
mm,
So if we take care of all these issues, the anesthesia part, it should be able to be implanted early. It's just like
mm.
somebody who has heart problem. If we say,
Yeah.
oh, too young, cannot go for heart surgery. But if the child has some heart issue that must be addressed, even at the during the first few days of life, they will do
Yes.
the surgery because
Mm,
it should be done in a center where they have good facilities. It should be done by the team that can take care of the child and the kids. So
mm,
I want to share with you, we managed to we were able to do a surgery in a 9 months old baby last year, and
mhm.
that was the bilateral simultaneous. Bilateral
Wow.
simultaneous, we do two
Two
ears,
sides.
two sides at the same setting, one after another. No, after we settle
Mhm.
the right ear, then we turn the hair and we do the surgery on the left ear on the
Okay.
same day, same setting. So the
I see.
recovery is actually the same as the one side of cochlear implantation. So this can be done.
Wow. Okay. So now since you did the surgery August 2020, which is last year about 7 months ago,
Yeah.
then what happened to the baby now? Can you just share a little bit to us?
Okay. The parents they have a speech therapist sessions with my speech language therapist, and or
Mm-hmm.
in fact she's an ABT. So
Mm.
what I get from the feedback, I saw the child. The CAP2
Mm.
score. CAP2 score means we are looking into the auditory performance of the child. The child is able to detect sounds, and the child already babbling. So can you imagine that the babbling is consistent, and the detection of the sound is consistent. Consistent means when there is sound, they know the environmental sound. When we say door knocking or the telephone or the car, so the child will be understand like she will run, and if there's a car sound, that's how they will detect. We call it detection. So we are very happy with the outcome at the moment with this baby. But of course, it's still a long way to start to speak
Mm.
normal child, but at least something positive that we have seen in this baby.
Yeah. So, Prof, we have been discussed a lot about children hearing loss, the diagnosis, and the intervention, and also heard some success story from your implantees as well. So, over here, I would like to just share hearing loss not only happen to the children, but sometimes it's more even affect the adults more. So, there is some statistics show here. Two-thirds of adults over 70 years old actually will have hearing loss. So I think this is like our parents or even grandparents' age, whereby 1 in 6 adults have hearing loss, make it the third most common physical condition they face. And then not only that, hearing loss will affect them in many areas. For example, if let's say someone if with some hearing loss, they tend to misunderstand what people say, then because of that, there will be more argument in the family, and the person who if let's say there is their wife is having hearing loss, the husband will keep on need to repeat. So this will also create a lot of frustration for them, and ends up they are having this unhappy relationship. And not only that, some of them will also very embarrassed to continue talk in the public or even with their friends, and they tend to isolate themselves from the society. They rather not to mix with others, and then not because they always feel very lonely, then this may also create some depression for them. And for elderly ones, because elderly is one of the age group being most affected by this hearing loss, elderly life quality will definitely affected if they cannot hear well, because they at the end sometimes I do see my patients, which is when they come in their children don't want to talk to them anymore because it's so tiring to talk to them. Always need to shout, shout, shout. Or sometimes they say, I don't dare to talk to my parents because my neighbor will thought that I'm shouting, I'm scolding my parents. So
Yeah.
imagine if no one don't want to talk to us, then of course we will feel very sad. Then research also show that for elderly nowadays, they are more easier to get this dementia or Alzheimer's, or even if let's say they don't have enough sound stimulation, the brain function will be also reduced, and they are also more likely to involve in this accident because they can't hear the car approaching them if let's say they are walking on the street. I would say that one of my patients came to me, they have hearing loss like about moderate level. Then I asked, how come now only you come to me? They say, because yesterday I almost get into this accident. So I can't hear the car approaching me. So I just feel like very scared. So better I get a hearing aid now. So these are the impacts of hearing loss. And however, even though sometimes in Sound Life, we already try our best to help our patient, yet there is some hearing loss. We find out that they are not benefit from these hearing aids. So, doctor, may I ask you, can the adults or those elderly actually also undergo the CI? If yes, then what are the criteria?
Yes, they definitely need hearing, isn't it? I think
Mm,
from what we have shared, if you can't hear well, this your life is so depressing. I can't.
mm,
I can't imagine if I can't hear people talking to me, and I like to listen to music and songs as well. So
Mm.
definitely, they are also the group that can be implanted. The only thing is the awareness about cochlear implantations in adult is not as much as children. A lot of
Mm.
people thought, no need lah, they can just use hearing aids. But the patient themselves must be motivated to know that they need the hearing. They need the hearing because they
Mm.
want to socialize, for example. They want to hear more. So that's where they are will come forward for the cochlear implantations. The criteria
Mm.
is the same as what I've shared. They need to be assessed by audiologists. They need to be assessed by my speech therapist. They need to do scan, yeah, because we need to know that in adult we are more worried about infection, for example,
Mm-hmm.
So we should we actually do the same assessment. Of course, except they are not going to be seen by pediatricians, but they will be seen by the physician. And
Mm.
sometimes we do have patients who needs to be seen by a psychologist because they are
Mm.
stressed with what they have. So
Mm.
you know that in our cochlear implant program, our oldest patients in uh, our patient. Do you know what is the age? You want to guess?
Okay, normally for I heard that the surgery because for cochlear implant need to undergo the general surgery, general anesthesia, right?
Yeah. Yep.
So 60.
Okay. So that's what people would thought. Okay, I think 60 is not too old yet, isn't it?
Yeah, okay, 70, 70.
They still need to go out. They need to interact with their family members, isn't it? Especially like now,
Yes,
they use a lot of phones. They use a lot of, I mean, the tele meetings with even their children. Remember the Chinese New Year, we cannot go back. Nobody can go home.
yes,
They go back
yeah.
hometown. They will use the tele, the using
The phone, the Zoom
virtual.
meeting for reunion dinner.
Yeah, so if you're elderly, how to if they can't hear well, that's very depressing. So the
Mm-hmm.
criteria is the same. They need to go for all this assessment. So
Mm-hmm.
we started to implant patient at 50s, at 60s, and a couple of years ago, we implanted the patients with 72 years old. We
Mm.
and our current age, the oldest is 79.
79.
He's fit for surgery. He's motivated. So he's
Mm.
so don't
So,
think.
so can I say, if let's say, after Prof, you undergone all the testing like the MRI, CT scan, everything okay, and their physical body is fit. Actually, regardless their age, also they can. How old are they? They also can go for CI if they really want to get the benefit of CI, and the
Yes,
hearing is really cannot help them,
yes, they
right?
are right. So they
Mm.
must try the hearing aids first. Then only they can appreciate hearing aids
Mm.
are able to help them. Then only they will talk about. They will come forward for the cochlear implantations.
I see. So over here, there is some diagram. We call this audiogram. So the audiogram here show that they are having this profound hearing loss on the right side and severe to profound hearing loss on the left side. Then after they fit with the hearing aids, the response is still like 60, 70, meaning you wear hearing aid, your profile become like maybe more severe. So still have a lot of these sounds cannot be heard. So
Yes,
after the CI, this is the diagram that I got from Prof, meaning to say that actually the person is able to hear near normal, which is the response is about 25 or to 30, which is very, very much improvement. Yeah, I'm
yes.
sure now they can hear almost like everything's
Yeah,
right.
so this lady, she was implanted at the age of 62. When she
Mm,
came to see me, so this is my communication with her last year, 5 years
mm,
of like implantations. So
mm,
her, I asked her, would you recommend cochlear implant of your age group? Who has hearing loss? And this Madam LGH say yes, because we live longer now, and our quality of life would be better if we can hear better. Well, she speaks
mm,
English, so these are her words. Huh? So I asked her another questions. My second question to her was, do you think you should have the cochlear implantations done earlier rather than 5 years ago? Then she said yes. The only thing is nobody referred her earlier to me. And she was referred by her sister-in-law, and she's actually my sister's friend, because she
Oh.
knows I do cochlear implantations. So a lot of
Mm.
there are some professionals still don't they are not aware that adult can be a candidate. So this
Mm.
lady, she said yes, because if she knows that cochlear implant can help her to hear better and more beneficial, she will have come forward to about to come forward to do cochlear implantation or to seek for advice for cochlear implantation earlier. So I asked her another question. I said, okay, well, now you have your cochlear implantation. So her next questions that I asked her was, what is the best thing that you have experienced? What is the best thing that CI has helped you? So this is the lady. She said, cochlear implantation has brought happiness to my life. That's what she said. Because she can
Mm.
interact with people, she can attend the daily mass, because she's a Christian. She attend a church service. This is before MCO, obviously, and
Okay.
but she understand that this need mapping, because this
Mm.
mapping is something that is tedious but is needed, and it's part of the process. We have warned her about this process, so she's willing to accept the process needed for her to hear better again. So this is the
Mm.
lady is very happy after the cochlear
Mm.
implantation. Before
Wow.
as you know, like, we can still like shake hand and everything. This lady
Yeah.
not only shake hand with me, she will give me a hug, and she will kiss me on my right cheek and left cheek. So
Wow. She loved you, Paul.
the first time I was like a bit shocked. Oh, okay, this lady. Then my students will be staring at, who is she? It's like, she must be
Mm.
very happy, to have.
Yeah. Yeah, that is definitely given like our title today, second chance to hear it again, and not only you are able to hear again, you actually get also the second life,
Yes.
different interaction of life with the surrounding people. So, Prof, I also since the next slide having some pictures.
Mm,
So,
yeah.
are these actually cochlear implantees as well? They are so happy.
Yes, you can see. So you can't tell, right? They enjoy life.
Yeah.
See that? These are all my patients. Of course, there's one with the parents, the mother. So
Mm.
the child can attend school. The child that the other boy, he attended two school. One is the religious school, and another one is the mainstream school. And the children and the parents, we went for the marathon one day. And the other girl, you can see she was in the sea and she enjoyed water. And the other two, the brothers and sister, both has cochlear implantations, and they would
Mm.
you can see that. So they're so happy. Their life after cochlear implantation, as long as they can hear, they can communicate, they enjoy life like any other children. They should be
Mm.
given a chance.
Yes, yes, I totally agree. And I would say that one thing about cochlear implant, because somehow they do understand that for this severe to profound hearing loss people, they cannot take off their device. So they do have something waterproof
Oh yes.
features to take care the speech processor, so that they can also still use the cochlear implant under the sea. So over here, I also have one of my audience, Miss C, which is she's a swimming coach, and she has been waiting to actually have the waterproof hearing aids one. Last time Siemens used to have it, but now they no longer have it. I think all the manufacturers don't want to venture into this part because it's so hard to actually get the balance between the batteries and also the waterproof features for hearing aids. So hopefully one day we can also get some waterproof hearing
I'm
aids.
sure we can.
Yeah. So, Prof, we are already up to 10 p.m. Just nice. Originally, a bit late for our schedule. So over here, there is some questions being asked. We have many audience over
I see.
here to ask some questions. So Let's see from Vicky. So Vicky is actually asking what kind of person can't do CI?
Can't do.
Yeah, cannot do.
Okay. We need to look at the whole picture. That means we need to see. Of course, if the hearing level is no, I think it's can't do. Can't do CI. First is these patients need general anesthesia. If the patient has very severe or serious medical issues that when they go for general anesthesia, the risk is so high, right? So you have to think about the risk and weigh the risk and benefit. Other than that, very very abnormal anatomy. When we need CT scan and MRI, very very abnormal anatomy where when you do surgery, you can't actually find the cochlea. There's no cochlea for us to put in the cochlear implantation device, the electrodes. Okay. For those without the one with the high small nerve, it's actually a relative contraindication. Relative means we need to do tests to see whether there's still any residual functions of the nerves. So some of the patients with small nerve still benefits from cochlear implantations. So I hope that answers. Of course, there are some children very abnormal in terms of multiple issues, certain syndrome which is so difficult where the child can't even respond to, when we want to put any device, the child just can't respond at all. So must remember after cochlear implantations, we need to do mapping. Okay, when we do mapping means we need some form of reaction from the child. So these are all things that we will say relative contraindications. They need to be assessed thoroughly.
So meaning to say that if let's say not sure they can do or cannot do, one of the way is they have to go to see the ENT surgeon that provide this cochlear implantation and then go through the thorough test. Because whatever you mentioned just now, the only findings that can be found from there is actually from the CT scan, MRI scan, and also test some of the reaction whether they are sensitive to some anesthesia drugs, right? So they can't be they can't undergo the GA, then they can't do the test. Yeah. So that's one very good question from Vicky also. She's asking, hi Prof Go, does child severe hearing loss need to drop until profile then only can do? If let's say the hearing aids, the answer is no.
No, because we must remember, I think earlier and myself, we showed the audiogram. If you remember the audiogram, the hearing level has threshold, that means the severity. But another thing that you must look at is the frequency. That means you're looking into low frequency, mid frequency, and high frequency. There are cases where the hearing loss very bad or profound at high frequency, but the low frequency maybe can be aided well with hearing aids. So these kind of cases is a good candidate for cochlear implantations. We have many types of electrode nowadays where we can try to preserve the low frequency if it is still very, very good, like 20 decibel, 30 decibel. But if the high frequency, mid frequency is so profound, even with hearing aids, the child won't be able to hear high frequency well. They won't be able to speak well, I have patients who are in their 20s, 30s come to me now because they can't hear high frequency well, but they're already in their workplace. And they realize they can't hear well in the meeting. So they can't catch the sound. When we speak, like now when we speak, actually we're using a lot of different frequencies. High frequency, low frequency, mid frequency makes a good sentence. So you need to hear well in all the frequencies. I think that's where earlier you can show there's the frequencies.
Yes. So over here is the audiograms. How we analyze is that from low pitch to high pitch, and then over here like the blue banana shape. This is called, we call it speech banana. So over here got the different speech vowels or even consonants, the energy line on. So if let's say a person who is having this hearing loss, but after wearing hearing aids, we do the aided testing, we still find that they are not able to hear well at a high pitch, then the person actually tends to miss out those speech cues like the sh, or even like the F sound. So if you are missing that, then the sound like speech, they will hear it like beep, beep. So it's like totally different meanings. So this
Yes.
is what Prof have mentioned. So the answer for this should be no need to wait. It's actually depending how whether the hearing aids can maximize and help them in their listening. If let's say the aided testing show that high frequency is still not being aidable even with the most powerful hearing aids, then the child actually is a or the child or the person is also a candidate for CI. Can I say that, Prof?
Yes, yes, you are right.
Okay. So there is also another question from here, Lai Ping. May I ask, is there any risk to CI?
Okay, I think this is there are two things. One is the anesthesia risk, the general anesthesia. Another risk is the surgery itself, the cochlear implantation
Mhm.
surgery. The anesthesia risk usually is very low if the patients do not have any medical problem. Means
Mm,
like no heart problem, no severe lung issues,
mm,
there's no medical problem that causing issues with general anesthesia. But
mm,
yet nowadays we have very good anesthetists, intensive cares as well. So
mm,
I remember I have one patient out of so many patients.
mm,
I have one patient whom I need to uh, the post-op care was in the ICU for a night because of the
oh,
lungs wasn't very good, but the parents understand. So that is
mm,
a case by case basis. We look at the risk. How high is the risk? Usually it's very
mm,
low. But the cochlear implantation surgery, yes, there is the risk. We're talking about simple as a swelling, the wound infection.
mm,
Another thing is the facial nerve. I think that's where people will talk about because this surgery needs to go need to do we need to do a mastoid surgery. When we need to do mastoid surgery, we look for the promontory or the inner ear, the cochlea. We will encounter facial nerve. So this is the facial nerve injury is one of the risks. But
mhm,
I would say that of course you need to be very careful. And there are times where we have a very small percentage, less than 5% of our program, our cases have this injury, and all of them
mm.
recovered well because we know that it was just a swelling. In a difficult case, sometimes it can have swelling, but they will recover after a couple of weeks.
I see. So, Prof, thank you for the answer. There is another interesting questions, which is yes, general public don't know how long is the CI last? Is it lifetime? Especially
Oh,
you say that the surgery is like insert the electrode inside the ear, right?
yes, it is. When you
Mm.
put in this, that's why it is it's titanium, and whatever is the electrodes we put in, we don't want to take it out, okay? Because it's for life. But that is internal part, the one that needs surgery to be inserted into the cochlea. But remember, I mentioned there's another component, the speech processor. That one
Okay.
is outside. That one will be like wear and tear, that need to be changed or upgraded.
Yeah, yeah, correct. So actually, I also see there is another questions. Is there any maintenance uh, for the
Okay.
CI after the implantation? So to answer this part, as the CI we mentioned, there is an internal part, there is an external part. The internal is actually the electrode being done during the surgery, insert inside the cochlea, and the
Mhm.
external is we need something called speech processor, and
Yes.
then is something looks like a hearing aid. So the speech processor still need to use battery, and because sometimes due to the weather, due to the sweat, sometimes the speech processor will experience the same problem like hearing aids, like having corrosion and breakdown, and some of the coin is like breaking. So that's
But
why
not
need
too bad,
to
huh?
do the
Okay,
maintenance.
implantations, I think nowadays the if it's just due to sweat, If it gets spoiled, then terrible. They would need to change many times. The
Yeah.
the current speech processor has a very good quality where they have this, we call it IP. What is the level of the water?
Yeah.
So that is
Um,
something that they have. But the only thing is, as you mentioned, there is a cable, there's battery. The main thing is the battery. The battery need to be changed unless you get something rechargeable. Nowadays, there's
mm,
types. So these are the usual maintenance. Of course, if the child has not thrown it away or did not take care of the processor well, then that may need to be changed. Depends on the conditions.
yeah, yeah. So, Prof, actually, there is also another question. If the child having hearing problem, does he or she will be dumb? I would say meaning like mute lah, don't know how to speak. So
Then
usually from your experience, yeah. Sorry?
I think people say deaf and dumb, right? Because deaf, you cannot hear, you cannot speak.
Mm,
This is what we have been talking about the whole the 1 hour. The
mm,
ear is the doorway to the hearing center. You
mm.
cannot hear, you cannot talk because the brain didn't hear anything. When they never hear anything, what to say? They don't know what to say. So that's why they coined the words in the past, very layman term is deaf and dumb. You cannot
Mm,
hear, you cannot speak because the speech center, the hearing and speech center did not develop. Okay,
correct.
where they call it cannot hear, cannot speak.
Yeah. But everything of this can be actually changed, or we say that the impact will not be happen if, let's say, the hearing loss is addressed early,
Yeah,
right?
yeah,
So as early as 6 months old, when the baby is like 6 months old, we can already feed them with the hearing aids, or or even at 9 months old, Prof had to experience to do the surgery, the CI surgery for a child. So if we can address this, then the child can, it's still possible to actually have almost near normal speech
yeah.
development
Maybe I
from
want to add on. There are a group of children have abnormalities or other additional disability. So these are the group of children where we say it is a relative contraindications. That means
oh,
when they use cochlear implant, they may be able to hear better compared to hearing aids, but their speech development may be very, very delayed. So this
mm,
group of patients, we have a lot of discussions with parents and the group, the team members, because we want them to understand what is the expectations of cochlear implant in the patients who has additional disability. If they can hear better, for
mm,
example, I have a parents who said, it's okay, I'm willing to spend this because I want my child able to hear when I call him or her. Even
mm,
after 3 years, he or she call me mama or papa, I am satisfied. That's what the
mm,
parents told me. I have an experience of abnormal cochlea. We call
mm,
it cochlear cavity. There's no two inhabitants of the cochlea.
mm,
After a couple of years, when I asked the mom, do you think it's worth doing this for your child? She said yes. She said, Prof, even though the child is not able to speak like normal, but the child can hear when I call him. The
mm.
child turned to me when I called consistently. And after a few years, I think it was after 3 years, she said, and she was in tears, she said, Prof, my child called me mom.
Mm,
It was so touching at that time because that case is a relative contraindication. And we
mm,
told mom, we
mm,
cannot help you to get the funding because this is really a relative contraindication. She said, it's okay. I'm willing to spend the money for my child because I want the child to be able to hear. Of course,
mm,
not entering mainstream. There are group of patients where we say can hear better, but
mm.
probably unable to speak like some of the children or good outcome like just now I show you those entering
Yeah, yeah,
university or what. So there is a
correct.
small group of patients may have other issues.
Mm, I see. That from this case study, we can say that sometimes hearing is very precious, and you only can understand how precious is it until you lose it,
Yeah.
right?
Yes.
Yeah. So it's very good. So, Prof, there is actually one audience asked something out of CI.
Okay.
So it's asking about nowadays because many people has been consistently using this headphone, earphone, and then it's so common, especially among the children who are going to school. Sometimes they cannot go to school; they stay at home attending the virtual class. So any special advice you want to give them? Whether is it something like aside, other than don't ask to turn the volume so loud. So any other advice you want to advise them? Then secondly, there is he's asking as a E&D consultant, do you yourself use or advocate any device or gadget for hearing care? Thanks.
Hearing care. I think the first one you can answer, Alia. That should be
Yeah. Okay. So over here, if let's say those who have been follow Sound Life Hearing Facebook Live for this 1 month. So for the first talk that I have done with Dr. Chin in Mandarin is talking about whether headphones are dangerous for us or not. So to make it short, is like normally as long as you use it at a safe volume, then your hearing will be protected regardless the timing. So how safe is safe volume? If let's say you can use it below 60%, then it's still okay. However, we still advise you to follow the rules 60-60. Every 60 minutes, if you are using at the 60%, then you have to just rest yourself and then later on you continue. Then if let's say you sometimes due to certain situation you have to use it at a louder volume, so 80-90 rules is another rule that I recommend, which is for 80% of the volume you use it 90 minutes, then you have to pause. You just stop using, then don't continue anymore. So one of the way why people tend to use louder volume is because the environment is noisy. So maybe choosing a noise cancelling earphone is a good choice. So yesterday in my Facebook Live, I was also invited under Realme to give some speech about noise, so people can go and watch it. They just launched a very affordable noise cancelling earphone as well. And then another thing is, if let's say you are given the choice either to use the earphone or to use the headphone or to use a speaker, I would say speaker is always the best because speaker is further from our ear. So sometimes when we use like this, we tend to increase the volume without realizing. If you are using speaker, people beside you hear that you turn too loud, they will remind you also. Yeah, so this is advice to be given. Then secondly, is that advocate any gadget for hearing care? So I don't think we want to advocate any special brand. Prof, do you have any particular brand?
I think you have answered the first and second question, Alia.
Yeah. Mm.
Actually, like you can see now, I'm not using any earphone because I'm in my room. It's quiet, and I do not want to, because I spend 1 hour, so I do not
Yeah.
want to have a very direct, loud noise to my ears. So probably I'm also very sensitive because I'm ENT surgeon doing hearing.
Okay, even though I'm using, but I put it, my volume is only 27 out of 100. So,
Yeah.
so audiology is also particular.
I think
So,
that your advice is important, and they can play back. You can ask them to see back your face.
yeah, so for those who understand Mandarin can always go to the launch, the live that we play. We had organized it during 5th of March. So you can play back again and then to
Now,
watch again to know the
another
details.
thing is the handphone. I remember earlier you mentioned that Android Samsung has the noise level. Actually,
Yeah.
I to have okay, and I check it already because
Yeah.
my student, my voice is quite loud. I
Okay.
speak to a group of patients with a hearing problem, but I also have a lot of students whom they have to hear what I say in the lecture in the ward round last time.
Yeah.
So I say my voice is quite loud. Today they actually tested. They put their iPhone beside. Oh, do you know what is your level this time when you talk? Don't tell me it's very loud. So it's actually a measure. So you know that at that kind of environment, what is the noise level? So I think these are
Yeah.
the things that we should know the hearing care on our own when we have this kind of gadget to help us to know. So we prevent. We want to prevent this hearing loss due to noise.
Correct. So the thing is actually just now what you mentioned is called Sound Level Meter app. So for those who are interested, you can just go to your Google Play Store or even iTunes to download. Sorry, it's not iTunes, it's App Store for
Yeah.
Apple products to download this Sound Level Meter app, or the short form is called SLM app. So for this app, you can actually measure your surrounding, how loud it is. So the dangerous decibels is actually 85. So once it hit 85, you can have maximum 4 hours in that environment. If let's say it reach out almost 90, every 3 decibel increase is actually reduce half of the exposure time. So if let's say it reach like 91, then you only can stay in that situation 1 hour maximum. So if let's say it hit up to like 100, then you can only stay for 3 minutes like that. So you can use that to actually self-monitoring. And one of the way, if let's say you really cannot, you have to stay in that situation for a longer period, then please at least prepare an earplug with you, or you prepare your own ear to actually do like this to reduce the noise entering your ear, because we do have some clients after exposed to loud noise, even though they don't have immediate hearing loss, but their hearing is less sensitive than the other person. And then some of them even develop the tinnitus, which is the this kind of noise 24/7. You don't want to get that. I'm sure that tinnitus is prof. You also encounter a lot of patients come to you.
Another topic is a big topic.
Yeah, it's a big topic, so we can arrange another time. So thank you. I think we are almost exceed our time, and then thank you for all the audience. Currently, we have almost like 38 who are still staying with us. Thank you so much for tuning in, and again, thank you, Prof, for actually spending your precious Friday evening night with us with Sound Life to actually.
Thank you and good night.